was going to tell you a little bit about Dr. Twyman. She is a medical doctor who has been practicing in the field of addiction since 1992. She's certified by the American Society of Addiction Medicine. She's taught at various colleges and university level courses. She's on the staff of the Salvation Army Homestead, a long-term addiction facility, and is the medical director of Renaissance, Ontario's largest residential treatment center for alcoholism and drug addiction. So welcome, and Dr. Twyman.
Thank you very much, Kathy. So welcome everybody to this workshop on food addiction. And as Kathy's already said, this is a talk where I'm going to introduce the whole talk by one testimonial, and then I'm going to do the first part on addiction itself, food addiction, and then part two after break. I'll continue that, and then I'll end with the panel. And the idea is really to state the problem and then present the solution as it stands today, as what we have today. And really it's a call for, we need more services with this perspective in mind. Okay, we have these kind of really broad categories, just known as eating disorders, not otherwise specified, like compulsive overeating and binge eating disorder. They don't have such clear diagnostic criteria, but the idea is somebody who's compulsively overeating, eating all the time, either the grazer or the binger who's eating all the time, or thinking about it all the time, or the binge eating disorder, which is kind of like the first, but you have episodes of binging. So not as clear, and lumped under this eating disorder not otherwise specified. And how do we treat that? As I said before, with the medications like antidepressants and orlistat, those kind of things, or behavioral techniques like controlled or moderate eating. Okay, now let's look at this phenomena from a substance abuse perspective. So these are the criteria for substance abuse. These are the criteria that I use when I see somebody for alcohol or cocaine or crack and now food. And let's see how well they fit. So you can think about yourself or think about somebody you know, or just think about it and you'll see. So substance abuse has to lead to some kind of significant distress. And it has to be at least 3 of the criteria to get the diagnosis. We just need 3. I'm going to tell you what they are in a sec. And over the last 12 months. So if it's just the last month, that's not good enough. Okay, so number 1. Patient has suffered tolerance or withdrawal symptoms. So what does that look like? I have a piece of, I really enjoy a piece of cake or something, and I really liked it. It's really exciting, and then the next day I really like it and it's exciting, but at some point it's kind of now boring. And if I want to have a really nice day, I'm going to, because it's my birthday or something like that, I'm going to want an extra big piece. I've kind of become tolerant to that amount. Or withdrawal. I've been eating sugar for the last, dessert every meal, and now I don't. And what happens? Irritable. No, I'm sorry, the Starbucks is closed. Oh, we ran out of muffins. Oh my God, there's no bagels either. What? What am I going to do? The irritability and whatnot. And that can be beyond just the hypoglycemic crash, which is the sugar and then you crash. Is this am I selling you so far? That's only one criteria. Patient has frequently taken more substances than planned. I'm just going to have 3 cookies. I'm just going to have a small bag of popcorn. I used to do this and then I would crush it down. And then I'd ask my friend, are you going to have the rest of your popcorn? So you frequently have more than you plan. I'm just going to have 1 small bag of chips. And, we all know that that's not likely. So that's 2 criteria. Person has spent a lot of their day getting, using, or recovering from the effects. Now getting. Let's think about people who, okay, if you're a cook, We had the example of the person who earlier who spoke, Helen, where she got into the business of bartending because alcohol was her drug of choice. Now, I don't know. I would be really interested to see a study on cooks and how many people. I don't know. This is pure speculation, and you can yell at me if you like, but it's a possibility. Anyway, the idea is if a person is in a food addict mode, spending a lot of time getting or thinking about how to get. Okay, I'm on my way home and I got to make sure that this is open and I'm going to get this and I don't want them to see that I'm buying too many, so I'm going to go over here too. And it becomes a whole elaborate ritual that takes up a lot of time. Using. I mean, it's, especially if it's a binge purge thing where you can just go on and on and on and on, then I mean, it can go on the whole night. It becomes like an obsessive compulsive thing. You know, you're washing your hands and you know you got to keep doing it. It just goes on and on and on. Sometimes people won't stop a purge or a binge purge cycle until their mouth is so raw because they've been throwing up so much or their stomach is so sore that they just cannot do it anymore. But they would still want to. So it becomes like this. Recovering from the effects. You've eaten so much that now you're sick, and that sickness usually lasts until the next day. And if it's a real sugar binge, you can be so sick that you literally have physical, back to number one, physical withdrawal symptoms of shakes. Shakes and body aches. I mean, it looks an awful lot like a regular addiction, like alcohol withdrawal. So that recovering could, and then the crash, the mood crash after, because you're way up there and then you crash down, and that crash can last for a day too. So you spend a lot of time. That's 3. Patient continues to take the drugs, or in this case the food, despite difficulties. Despite hypertension, despite obesity, despite diabetes. What else despite? Despite shame. Despite
the example you're setting for your children.
Yeah. Yeah. That's 4. Person has given up work, social or family activities. I'm planning to go to this, but I can't now because I'm so buzzed out. I can't go. Or I'm so full, I can't. I'm sorry, I know I was supposed to go, but I'm so sick. I'm just going to call him, I'm sick. Sorry, I'm sick. I'm not going to tell you why. An alcoholic doesn't tell you why either. They got a hangover, or they're too drunk. I'm just not, I got a headache. So it can actually impair work and social and family activities. Isolation, especially with food addiction, Helen, I thought really highlighted nicely the shame that's along this. I mean, I got to tell you that in my work with addictions, maybe because it's so we read about it so much now, and there's so many services out there. It's still, there's a lot of shame with alcohol, no question that there is, but it's a lot easier for an alcoholic to say I'm an alcoholic than a food addict to say I'm a food addict, especially when you imply some of the behaviors. There's a lot of shame that's involved there. Okay, number 6, last one. Person has made many attempts to cut down on substances. In other words, diets. How many diets have you been on? That's an attempt to cut down. Whoa, I'm eating too much sugar, I got to stop. And that is a perpetual cycle that keeps going. So you only need to have 3 of those in the last 12 months, or any period of time in your life for about 12 months. Are we looking at a very small phenomena, societal phenomena? No. I don't think so. And that is enough to give a criteria for substance dependence. Dependence. Abuse would be just 1 or 2 of those. You just do something to the exclusion of your better mental or physical health. Well, a lot of people say I abuse food sometimes, but actually I say I'm sometimes dependent on it is another matter. And once you fit those criteria, then we're looking at potentially different solutions.